Welcome back, everybody. Welcome to Pain Information. Always talk things over with a qualified medical professional, but this is an informational channel. I think today what I want to talk about is what do I do? People come see a pain doctor, they don't know what to expect. They come to see a healthcare professional about a painful entity, they don't know what to expect. It's kind of like a black hole. I guess you'd call it a black hole. It's a question mark. And so I'm going to give you some examples of things I deal with every day, and let's work through some solutions. Okay, so this is what I did. Saw this person just a little while ago, and real patient, real deal. All right, he comes to us complaining of back pain. Originally, he was complaining of other problems. He's complaining of back pain today, and I sit with him in the exam room. I think everybody knows what that's like. You go into an exam room, you have a limited amount of time with the healthcare provider, but sometimes you need a little bit extra. This is one of those days. So he's got an IV, and it's connected to a big box that, as the history would unfold, has antibiotics in it. So I had heard that he'd been in the hospital. He's an individual we've been seeing for some time. He came in today, he's a little disheveled, hair a little out of place. He looks like A, he's probably hurting, and B, he's just not feeling well. And he wasn't. He just wasn't feeling well. He had this back pain, so he was slumped over, a little sideways. We'll call it antalgic. That's a medical term. But the point being is this: what do I have in front of me? And what do I need to do? Big question mark is, how do I treat his pain? Back pain. IV. So let's expand the questioning. When we approach a problem, it's history, physical examination, medical decision making. Those are the three elements. We have to have those down. Within those three elements is a differential diagnosis, right? The differential diagnosis, those 5 rules. Pain is a description, it's not an entity. You must have a diagnosis. See, I don't have a diagnosis right now. I've got back pain, that's a symptom. Number 3, if you don't believe in the problem, you think it's entirely psychosomatic, you can't treat it. This is not a psychosomatic problem. This guy's got a real issue going on here. Number 4, know thy meds. So know thy meds means you check thy meds. So have some drug screens here that we did, inventoried those, and I did what's called a PDMP, or I checked the data registry on who's prescribing what in this area, in the state, really. I wish it went across the United States. We had a system we were working on that would do that. It's called NASPR, National Scheduled Prescription Electronic Reporting, signed by Bush. It just never got implemented. But we got what we got. And I did a criminal background check, as we do. It's a good idea. Do we change how we treat people? Not always, but it's important to know. And then, I'm just kind of looking and enhancing my database. What do I have? Because Rule 5, from a compassionate standpoint, I want to get rid of everybody's pain. But from a realistic standpoint, I want to improve function. This guy's not very functional. Do you have a fever, cough, chills? What do you have going on here? Well, I had that. Then I started on antibiotics. Okay, that's helpful. Well, what do they say in the hospital? Well, I have an infection in my back. You do? Do you have meningitis, which is inflammation in the central nervous system? That's bad. Nope, it's in my bone. That's odd. Having an infection in the bone is rare, odd, and it starts narrowing the differential diagnosis. That being, what could it be? What's that diagnosis? Rule 2. Okay, you have back pain from an infection in the bone. I'm getting it a little more now. What is a common reason you have an infection in the bone? Well, one of the common reasons is uncommonly seen. And so at the top of the list, I have to ask those questions. IV drugs, some type of systemic infection from something. Do you have a cut, infection from somewhere? You're diabetic, or you're predisposed to having these problems. No, he's not a diabetic. Do you use IV drugs? Well, I mean, I'm obligated to look. Nothing. You can have needle sticks anywhere. I didn't see it, but it's winter time. I didn't do a complete inventory, but let's just say he said no, okay? All right, number 3, he's getting IV antibiotics. They were concerned, and that's a staying in. It's not coming out immediately. It's been in a while. So ongoing infection is being assessed by blood work and by individuals that are sincerely interested in his best outcome because something's up. Well, so I'm looking through his drug screens, and I go back and there's a couple hints that there may be some problems. And then I got a drug screen that says methamphetamine. Oh no, I don't do that. I get another drug screen, methamphetamine. 2. These drug screens are highly accurate. There's stuff crime labs use. They use technology that is really, really accurate. So, okay. The most reliable thing we can take from a patient is their own description. But the most important thing we do is trust and verify. And so, okay, I'm going to get some records, as many records as I can. Those come at a snail's pace. We try to get them quickly, but even though this is the world of electronic health records and medical records, and you'd think it'd be digital speed, zoomy, it's not. It's not at all. And so we call for those records, but I have to first, do no harm? Interestingly, people think that's a Hippocratic oath. It's not. It's not an Hippocratic oath. I'm pretty sure. So, all right, first do no harm. Well, I'm looking here, and I'm seeing that he's getting oxycodone from somebody, and I can run down that doctor's name, and there it is. 120. Oxycodone, 10 milligrams. Well, he has a legitimate need. He's got a back problem, and it's a painful back. So I did a urine drug screen today, nothing in there. It's a point of care cup. It's not always completely accurate, but it's pretty good. There's no evidence of oxycodone. So what am I going to do? Where's the oxycodone? Well, I didn't take it today, but we probably see some oxycodone or metabolites. And the metabolites tell a story. It's easy for some folks to come in and fool a drug screen or attempt to fool a drug screen by just dipping a pill in the urine and it says oxycodone. But if there's no metabolites, it means they're not taking it. Or the metabolites are really low. It's important. So we have to know how to interpret drug screens. Still, we are not accusing anybody of anything. We got to take care of this guy. He has a legitimate need, legitimate pain. I don't want to hurt him, and he's getting meds from another source. And we've got a couple aberrancies on the drug screens. Methamphetamine, where did that come from? Oh, bloody murder, I didn't do that. So, okay, what are we going to do? All right, what did I do? Well, you think by appearance I'm being judgmental? No, I'll tell you, another patient of mine whom I saw a few days ago, he comes in with these shirts, the Walking Dead shirts, and these, I don't know where they get these t-shirts, but they're cataclysmic movie events that I've never seen these movies. But he's got long hair, his bushy hair, goes to work, got hurt on the job, workman's comp. I take care of this guy. If you took one look at him, you'd probably say, But he's one of the best patients I got. He's an incredibly good guy. He wanted to go back to work. We got him back to work. I mean, you can't just look at somebody and say, You've got to use the skills you have and your educational experience to better help the individual. So, all right, let's just say there was some IV drugs or some drugs somehow that got this guy infected here. Well, the next question I have is, what else is getting bothered? I mean, if somebody does use IV drugs and it's a contaminated issue or a process, what else am I going to look at? We got to make sure kidneys are okay. We got to make sure everything else is okay, blah, blah, blah. Brain's okay, he's talking fine, good orientation. Heart. Has he had an echocardiogram? Well, I don't know that, so I got to talk to the primary care, right? Primary care. So I'm going to put a call into primary care. I don't know who the other individual that was writing for all this oxycodone was, but this individual has a patient care agreement with us that they'll only obtain medication from us in one source, pharmacy being source, and if there's a problem, they'll communicate with us. We're pretty clear on that. And this didn't happen, so that coupled with the fact there's nothing in his urine, we got some questions. We got some explaining to do. So what did I do? Well, I did not prescribe to him. First of all, he has meds, or should have meds. Number two, I need a pill count. I need him to come in and do a pill count. Show me where the rest of these meds are. He didn't have them with him. We do pill counts. Number three, communication. When all is said and done and the dust settles at the end of the day, communication is everything with what we do. Because what we do is time pressured. Yeah, everybody knows that. What we do is also requiring a clear understanding how to take a foundation of information, do no harm, and move to the next level. He's got an IV. He's got a problem. Let's look at other potential problems. Number three, we have to reduce the risk to the community. Or four, I don't know what number it is. Four, we have to reduce the risk to the community. Is that medicine being diverted? I don't know. So we have him come back in the next couple of days. Well, anyway, incidentally, you know, for the record, he did bounce a check. That's okay. I'm going to see him anyway. I'm not getting hung up over that. I mean, it's a number of events that lead us to a direction we have to go to help him, right? We need to help this guy. If it's a problem with dependence and addiction, we need to know that. If it's a problem with pain, we need to understand that, but there has to be a distinction. Lines can be a little blurred, can be a little gray. Pain and addiction can be together, and we have to understand pathways and processes to best come to an outcome, right? Acute pain happens chronically, and chronic pain happens acutely. And number three, if you don't believe in the disease, or you think it's entirely psychosomatic, or you think there's another issue, you can't adequately treat them. Well, I'm going to treat him. And I believe in the guy, and I'm going to do what I can to get him to a better place. And that's kind of what I do. It's the next patient in the next room we got to go to now.